Welcome to Pediatric Pioneers, a MedBridge podcast where we conquer challenging topics for the pediatric therapist through conversations with pioneers who have blazed new trails in our practice. Our aim is to deliver actionable takeaways for practitioners like you. To receive continuing education credit for this episode and access bonus resources, make sure you check out medbridge.com. Hello, I'm your host, Nicole Quint, and I'm an occupational therapist with over 20 years of experience in practice and academia, specializing in pediatric practice and the improvement of occupational participation and performance through my expertise on executive function, visual perception, social emotional learning, sleep, and sensory processing. It is my passion to support pediatric therapists like you so that you can best serve the families under your care with evidence-based practice solutions, easy to implement advocacy approaches, and new ways to lean into your skills within the challenging pediatric landscape. Hello, everyone. Today, I'm excited to be joined by Dr. Elise Bloch, an expert in the area of patient and family engaged care, or PFEC. We'll be diving deeper into this topic, including recent research and actionable takeaways you can implement right away. So welcome, Elise.
Thank you. I'm glad to be here.
Could you get us started by sharing just a little bit more about yourself?
Sure. Well, I've been an occupational therapist for over 40 years, and I've been working in academic settings for the last 30. I became interested in patient and family engaged care as a pediatric occupational therapist, then as a mom of a child with serious illness, and now as an educator, advocate, and mentor.
Yeah, we know you as a prolific educator here in Florida, so we're happy to have you join us today. I know this is a passion area for you, so tell us a little bit more about what initially attracted you to patient and family engaged care, how this passion has evolved over time, has become kind of your life's work, because I know that you have a personal story attached with that.
Sure. So as you know, I've been a pediatric occupational therapist, and in that capacity, I worked in schools, early intervention, NICUs, PICUs, outpatient, and over, I heard moms tell stories about how they knew something was just not right with their child, and they were often poo-pooed or not really heard by medical providers. And typically they were right. And if it was a mom who was a strong advocate, they would go see another provider. And if it was a mom who didn't feel empowered to do that, that child lost valuable early intervention time. I saw this over and over, and it was really concerning. And I began to think, are we really listening to families? And I started looking at this for my dissertation area, looking at attitudes of occupational therapists working in family-centered care. During that time, I always think that God had a very ironic sense of humor, as he wanted me to do some of my own personal qualitative research. And my son at age 6 was diagnosed with acute lymphoblastic leukemia. Yeah. I felt really blessed to have worked in a children's hospital because I, as an occupational therapist, knew Hospital 101. But I didn't know acute lymphoblastic leukemia 101 and bone marrow transplant 102. And it is an incredibly humbling experience to be a mom and be on the other side of that plinth or bed. And actually, the first 2 weeks that we were in the PICU, and then when we moved to a floor room in the unit, there was a young man in the next bed, and one of my former students came in the room to treat this young man, and she sees me, I'm in pajamas, my hair's a wreck, and she says, "Dr. Bloch, what are you doing here?" And it was like, I'm here with my son, and I'm a mom. And what I saw was, I want to say disheartening, but really frightening at times, because what I quickly saw is that families that didn't have good health literacy skills or were non-English speakers or didn't feel comfortable advocating for their child, their health outcomes were not as good as families who did have that skill. Right. And in our time, we were in 2 major healthcare systems over a 5-year period. And I, at that time, caught 2 medical errors. And it was incredibly complex. He had a 2-year protocol on when he relapsed. Then we had another protocol for his bone marrow transplant. But my witnessing of that journey and all the emotional overlay that goes with that, and seeing what families go through, really made me shift gears from family-centered care in the school and early intervention setting to family-centered care in the hospital setting. And in fact, the hospital we were treated at asked me about halfway through my son's treatment to become part of their Patient Family Advisory Council, which was a newly established council of moms and dads who are frequent flyers to make the hospital safer. And I've served on that council in numerous capacities for the last 20 years, and have been really blessed to have started education initiatives for the medical and nursing residents there. And that is a labor of love for me, because the only time anyone's happy to be in the hospital is giving birth. And having a child who's sick, and a child with cancer is a life-threatening illness, is the most scary, vulnerable time for families. And if we can make them safer through that journey and give them the support they need, we're doing the best thing that we can. So currently, I'm on the Patient Family Advisory Council, and then I serve on a few advocacy groups at the state level, which I feel really blessed to do, because there's such a great need all over the country. But in Florida, where we have a lot of non-English speaking families and folks from vulnerable groups, it's incredibly needed.
Yeah, I think, you're talking about your personal story as well as the occupational therapy connection with a former student. I don't know if everyone even really knows this is available at hospitals. So, Elise, I heard you say a little bit earlier, that it's really important to talk about this topic of patient-family engaged care, and previously known, by the way, as patient and family-centered care. And occupational therapy, you have your personal story. You had even the story where you ran into one of your former students. And I don't know if OTs always know that this is available in certain hospitals. And I know it's starting to trickle into more like smaller clinical arenas. But, you said something about health. This affects health outcomes. So what questions should we be asking as therapists? Is there anything we should be questioning about this topic? And really, kind of helping us understand why it's so important to what we do.
Great question. And for me to do that question justice, I want to give some historical context. So back in the 90s, there were a couple of high-profile medical error cases. Josie King was a 2.5-year-old who died at Johns Hopkins because no one listened to mom. Betsy Lehman was a Boston Globe health reporter who got a chemo overdose and subsequently died. Libby Zion was a 20-year-old college student who died in the emergency department at New York Hospital. Her dad was a New York Times reporter and did a whole investigation. And because of his efforts, they had the Libby Zion law in New York State, where attendings had to be in the emergency department and residents had a limited amount of hours that they could work. But these high-profile medical errors caught Congress's attention, and they commissioned the Institute of Medicine, which is now, as we know, the National Academy of Medicine, to investigate and say, what the heck is going on? And there's lots and lots of thousands and thousands of medical errors. And they came out with a landmark report, 2 landmark reports, Crossing the Quality Chasm and To Err is Human. And those reports said, we can't blame the individual occupational therapist, physician, nurse. The system is broken, and we need to have family-centered care, and we need to be transparent, and patients need to be part of the process and informed and given information in ways they understand. Prior to this, if we're going to flash back to the 1950s, if you were a mom who had a child in the hospital, you were considered a visitor. There were set visiting hours, and the hospitals were really set up for the convenience of the physician staff, where doctors were here and patients and families were on the bottom. Slowly, in the 1960s, nurses began to realize, gee, when we have moms and dads and their kids who are sick, They do better mentally and physically. And if you remember back in the 50s and 60s in birthing, when someone was giving birth, dad was outside. That is not the experience today. Today in children's hospitals, parents are considered partners in care and are there 24/7. That has slowly spread to the adult medicine world because of these reports. And they recognize that to make the system safer, we need families to be educated simultaneously. And I just want to put it in context. In the education world in the 1960s, we had families of children with special needs saying, wait a minute, our kids deserve an education. Prior to the Individuals with Disabilities Education Act in 1975, which was then known the Education of Handicapped Children's Act, if you had a child with a disability, the school district could say, sorry, we don't have to take your kid. But because of those families advocating, we had this landmark legislation now known as the Individuals with Disabilities Education Act that said every child is entitled to a free and appropriate public education. So these two movements in the education setting and the medical setting happen simultaneously, really because of patient and family advocacy groups. In the 90s, it really became mainstream in children's hospitals that for every children's hospital should have a patient and family director and a patient and family advisory council. And they soon recognized that, as I mentioned before, that it should move over to the adult world. And that's where we're at now. I will tell you that in the state of Massachusetts, recognizing that this is so critical, since 2005, they have mandated that every hospital has a patient and family advisory council, and they have to send a report to the legislators. Now, why is it a good fit for occupational therapy? As you mentioned, we all know that we are client-centered. We are good listeners. We really try to find out what's important to our families and what we could be doing for our patients. But I ask, are we truly listening to our clients and their families? I'm an old occupational therapist, and I remember when I was taught in rehab, adult rehab, everybody got a kitchen checkout. Now, there could have been a Latin male who would say to me, my wife's going to be cooking. No matter what you do, I will never be in the kitchen. And we still had to give them a kitchen checkout. That was not culturally humble. I mean, it wasn't really respecting their culture that would never happen. So again, I ask, are we truly listening? Do we ask? And there are 4 tenets of family-centered care. Dignity and respect, and that speaks to honoring that person and really listening to them. And I'll give you a really simple example. Some mom, when I was in the hospital, I didn't care if the nurses called me Elise, mom, whatever. But there were some other folks who didn't want to be addressed as mom. They wanted to be addressed as Mrs. So-and-so or Dr. So-and-so or whatever, or make sure the nurse or the doctor pronounced their name right and their child's name right. Respect and dignity, respecting their culture and what's important to them. The second tenet is information sharing. As I said, I had Hospital 101, but I got a 2, 3 or 4 page protocol. Now, I was fortunate. I have medical people in the family that I could ask, but I also asked my doctors to explain things in simple terms, not only to me, but to my son, because he was the one going through treatment, that he would understand. Are we sharing information in a way they understand using health literacy principles? And the other thing I want to say about that is having a child in the hospital is frightening for the families and it's scary for that kid. And you may have to tell them this information more than once because their brain is so overwhelmed and they're so nervous and they're so anxious. So even though you might have told them 5 times, be patient and tell them again.
They're not feeling good, right? We also forget if the child is sick.
The child is sick, 100%.
Right. And I think that gets lost in the equation as well.
You know, when we're in the hospital as clinicians, that's our home. You know, we're in there, but we're not. And I remember going into the hospital with my son, and I would bring his favorite blanket. I would bring his school books. So I would feel human because I lived in the hospital for weeks and weeks. And I basically lived in jogging pants and sweatshirts, but I would bring perfume. Perfume for me made me feel human. You know, it was because that was my home for 2.5 weeks. Going to Publix was like going to Disney World. I mean, it was such a treat to get out of the hospital. The third principle is participation, which is giving patients and families the options to participate in care. We do this all the time as occupational therapists. Oh, do you want to come into the session and we'll work, and I'll show you what I'm doing with Johnny. Some families may opt not to because maybe it's their only break, and maybe they need to get out, or maybe do we give them that choice? And the last tenet is collaboration. And that speaks to the term of engaged care, which is collaborating at the system to make the system safer and more family engaged. And that is something that I don't think occupational therapists do. And not only OTs, PTs, nurses, all of us, we don't think about, oh, we're going to redesign the rehab clinic. Oh, this is what we need. Do we ever stop and say, what is that experience like for the families and the kids who walk in our clinic? Is the waiting room welcoming? Are there toys for the kids? Is there a computer with resources for them? Is the bathroom accessible? Do we think about the wayfinding, all of those things? And if you get families' input, then they are collaborating. And that's what we do in the Patient Family Advisory Council, where we collaborate with staff when they have issues of concern.
Mm-hmm. And the wayfinding is a big one. I don't know if people... I'm sure the minute they hear this, they'll say yes, because we've all been there where we've gone to some big hospital or something, and we're like, how do we find where we need to go? You start looking at signs and you're not sure, or there might not be signs, or they're vague and nobody knows, or they tell you the wrong way. You're not even sure where to park. So the wayfinding is a big deal.
And how much does it take for us to have a script when you have a new family coming to your outpatient clinic or your whatever? Oh, just remember, this is what the parking's like. And you know what? It's always cold here. So you may want to bring a sweater for Johnny, and let me show you a map of where the cafeteria is in case you get hungry when Johnny is in therapy. I mean, that takes like 2 to 3 minutes, but you're already setting a culture of making it easier for them. The other thing that I just want to make sure, because you mentioned the change in terms, the terms keep evolving. So the term family-centered care in the 60s really only applied to the pediatric world. Because of those 2 landmark reports, the Crossing Quality Chasm into Air is Human, the patient and family-centered term is across the womb to tomb, as we say.
Right.
Okay. And then the engaged care is the last term that's been in the literature from about 2017, because it speaks to collaborating at every level in the system. So just for clarification.
Yeah, I think, the therapists that are listening are going to say, yeah, the system is tricky. And I think it's easy to get overwhelmed. Systems, press on us as individuals. They are a machine. However, this is one of those exciting opportunities for us to make a change in the system. When you feel powerless, you're giving power to yourself as well as your clients. That's a big deal. So I think it's exciting. I tend to get very excited about, kind of working with system to make changes. And when you said it was, these reports said that the system was broken, it's easy to get down on that. But understanding that patient and family engaged care is an avenue to try to fix it in something that's very doable, I think is really exciting. So in knowing that you're involving the families, giving them a voice, and I think this is a great way for OTs to lean into our strengths and help those families really feel like they can join in on this and have their voices heard. I'm wondering, what does the research actually say about the benefits? Because I'm imagining all of them, but I'm curious about what is out there that we could use. Let's say I'm a therapist and I work at a hospital and I realize I'm not in Massachusetts and we don't have a mandated, patient and family centered care or engaged care approach going on. We don't have a council, and I want to spearhead it, and I'm feeling a little overwhelmed. We know that one of the best things is to have some literature of what the research says. So what does it say about the benefits?
Well, there's only about 40 years of research on this.
Right.
It gets more sophisticated as we go on. But the bottom line is the research says that when you engage patients and families, you reduce medical errors, you increase health literacy and getting the patient actively involved in their care. And the folks listening may be familiar with the Institute of Healthcare Improvements, triple aim. They also have a quadruple aim, which is that patient and family engaged care improves population health, patient experience, decreased costs, and satisfaction of healthcare workers. And there's also studies about hospitals who not only do we have to be patient and family engaged with our clients, but with the hospital staff, like to have a daycare for sick kids to show that we are caring for our nurses and their families. So and hospitals that really take into consideration the mental and physical health of their employees have less attrition and people are more motivated to work. I was really fortunate at the system that my son was treated in, where they had a whole patient and family engaged care training program and actually received the patient and family engaged care certification through Plaintree, which they were one of the first children's hospitals to do that. And in order to do that, they had to show that throughout their system, in their mission and in their vision, and that families we were sitting on ethics committees and patient satisfaction committees. And I'm happy to say that we provide education to the medical residents, nursing, and staff. So we're integrated throughout that system to improve the care. So that's what the research talks about, the quadruple aim. It also talks about that patient and family engaged care has spearheaded this patient advocacy movement, recognizing the critical need of patients and families on the team. And today in children's hospitals, in the NICU and PICU, they have family rounding where moms and dads, they're not rounding in a separate room, they're rounding bedside. And moms and dads are taught about the rounding system so they can add, I've been at Johnny's bed for 24 hours. This is what his color looks like. He's not eating it as much. Who else knows their kid better than mom or dad, or even an adult patient if it's a wife or husband staying with their loved one?
Right.
The other thing I will tell you about is because of the Josie King story, which was when they didn't listen to mom and sadly she subsequently died, is they started this rapid response team. So what is that? In the memorial system, it's called the help alert, which is when you come in, you are told by nurses or the people who orient you to the hospital, if you feel that your loved one isn't doing well or the patient feels he's not doing well and he's not getting heard by his medical team, he or she, they can call a number, the help alert number, and they will bring an outside medical team to evaluate the patient. And there's been research on that. And the research says that it's typically the patient calling about themselves or a family member. And like 90% of the time, the patient needs a higher level of care and is moved to the higher level of care because they're correct. So this speaks to the importance of families recognizing the subtleties and difference on their behaviors and their nuances and really knowing their loved ones and the patient knowing themselves. And oftentimes staff is busy or overworked or, not really listening. And that happens and it shouldn't happen. But today we have that help alert. And I always tell my students about the help alert whenever they tell me they have a family member in the hospital, because I want them to be as educated and to advocate for their loved ones in the hospital. And from occupational therapy lens, who are the most vulnerable people in the hospitals? The elderly, children, and folks with disabilities. Those are all the people that we treat.
Right.
So we need, and there's lots of research on that and the vulnerabilities of this population. And we need to help those families and those individuals for themselves to advocate for themselves while they are in the hospital. And that's that health management part of the occupational therapy practice framework.
Yeah. So we have that opportunity to educate them, like you said, and really help them be competent in this approach. And sometimes we can't just say, okay, let me tell you, this is the help alert. good luck, right? We could actually help someone advocate for themselves in that process. And, thinking from a pediatric lens or working with adolescents who have disabilities, this is something that could be a huge goal in occupational therapy, and have them be able to reach out, because there's such carryover into the next time they're hospitalized, or advocating for a wheelchair change, update, or things like that. Or, this is life, this is adulting. So I think that that's a really exciting piece to think about. So it sounds to me like, as occupational therapists and occupational therapy assistants, we need to make sure that we are really understanding the resources where we work, or resources available in the area of where our clients tend to go. That's a little challenging, but I think if you know the language, I'm assuming, do most of the hospitals have kind of a website or something that talk about that, where we could maybe learn a little bit more about our local community and things like that?
Are you talking about the patient and family engaged care thing in the hospital? Yes.
Like
they have, typically hospitals will have this is our director of family center care. If you have any issues while you're in, and they typically will tell you when their advisory council meets and how to get in touch with someone.
Mm-hmm.
If you want to join and that kind of thing. You have to be at a certain, the one thing I want to stress as a member of a patient family advisory council, as a patient or family, you're not there to gripe about your individual treatment or individual doctor or nurse or therapist. You're there to make that system better. So you have to be ready. We have at the hospital at Joe DiMaggio, we have lots of moms and dads whose children have died, and they come back years later because even though they lost their child, they feel so incredibly grateful for the love and care that they got when their child was in, and they want to make it easier for other families. And that also speaks to what you were talking about with supports. And I think we do this informally, that we may connect families with another family with their permission. But I think we need to do it more formally, because there's a lot of research on the benefit of support groups. I think that every family should be given that information, and family mentors. A family mentor is someone who has walked that walk. I was so grateful for our team when we were in the hospital, that when my son relapsed and we were going up to Duke for a bone marrow transplant, they said to me, "Do you want to talk to a mom who was there already?" And I go, "Yes, of course." Yeah. They connected me with her, and she gave me very practical advice. Do online banking. It's cold in the room. This is the school your daughter should go to, that the doctors and nurses would never have been able to give me, because they didn't walk that walk. So I think we do our families a disservice when we don't connect them with other families and support systems.
Mm-hmm. And there's that sense of community too. And I wonder, I know I had read something about, I don't know if it's said this way, a PCORI as part of patient and family engaged care.
Well, PCORI, which is the PCORI, right? So in the Affordable Care Act, which has a lot of patient-centered mandates in it. In fact, if you have a patient-centered medical home, which a lot of our complex care clinics have today, you get better funded. And that means you have to have a family member on that team. They recognize that we're often looking at evidence-based questions from the medicine side or from the clinician side. And they said, what issues are important to families? And PCORI is made up of advisors who are patients and families. And one of the issues that they're looking into, which is near and dear to occupational therapy, is falling in the elderly. That's a major issue that people identified it, because as we know, once someone falls and fractures their hip, the mortality and morbidity after a year is not good. So there's a lot of, the PCORI Center was established with the Affordable Care Act, and they give out grants, but it's based on issues that are important to patients and families.
So I'm thinking about, all this research, like you said, there's 40 years, how it's spearheaded advocacy, how we know that the families say that they want to have a voice, that they know their family or their family member or child best. We know that things like the help alert works because 90% effectiveness, that's insane, right? we think about that. We know that support groups are very effective. So, I'm sitting here thinking about all the occupational therapy providers that are listening and how they can translate this 40 years of research into their day-to-day in working and supporting families in whatever setting that they're in.
Great question. So if you're in a hospital, the first thing I would tell you to do is to find out if they have a patient family advisory council. I've worked with many students who don't even know their hospital has it, and many therapists who don't know their hospital has it. And let me just clarify, a patient family advisory council is like 60-40, 60% families, 40% staff. So staff can be part of, depending on the individual hospital, staff can be part of the family advisor council. And what we find is we typically have staff who also have kids or family members with special needs because they get it like at a different level. So if you do have a patient family advisor council, join it. Or if you have an issue in your clinic, bring it to them because they've experienced it. Some of the patient family advisory councils will 1 month have a focus group about their experience in hematology oncology. The next month, they'll share their experience in pediatric rehab. So you get to hear from people who are the lived experience folks about what works in your system and what doesn't. And I will tell you, when we first did this at the hospital, they were so afraid to do it that it'd be bad-mouthing staff. And that was not what happened. What happened was people really shared how grateful they were for the love and care they received from the staff, but also gave very valuable suggestions about what they could do better. And it was all said in the most respectful, caring way, and it was incredibly well received. So if you're in a hospital, patient family advisor council, if they don't have one, maybe you'd like to start one. If that's not within your scope, what about just having a focus group, an advisory council for rehab, and asking families to have a Zoom meeting and tell us about their experience? I know we have the Press Ganey patient satisfaction stuff. That doesn't always come back to rehab. So that's one thing. The other thing I will share is that cultural humility lens. And when I was a young clinician, I was also guilty of judging families. Why aren't they doing X? Why aren't they doing Y? And I shudder at that now because I don't live in their shoes. I don't take that child home 24/7 like they do. So to really respect where they're coming from and recognizing that they're doing the best they can and how can we help them? And we can do that through our occupational profile and partnering with them about what is important with that, with the birth through 3, the IFSP, what's important? What do they want their child to be able to accomplish? And then looking at the habits, routines of that family to make it happen. And I'm thinking about some of the kids that I treated in the hospital who sometimes I'm thinking about some AIDS babies that I work with and toddlers where the mom just wanted to play with the kid. And she was so grateful when we came in as OTs and just had her and showed her how to play with her kids safely, that she could have those wonderful memories. So, we're meeting the family where they're at. The other thing is that health literacy, teaching the family and the child based on their developmental age, about their medicine, if it's a diabetic, about their insulin, about their diet, depending upon what's appropriate. I will tell you, when my son was in the hospital and he was from 6 to 12, when he would know to ask anyone who came in his room, did you wash your hands? And a lot of the frequent flyers who are children who are in and out of the hospital, they become very sophisticated. We would walk into the emergency department every time he was neutropenic, and he'd walk over, put his little head up on the desk and go, "Hi, my name is Franklin. I'm in because I have a fever and I need a 22 3/4 gauge needle. I'm allergic to Duoderm. I have Tegaderm. Can you call Nancy on the 4th floor and she'll bring it down?" He knew. 8 years old. Kids know that, but we can teach them that so that they're safer in the system. And I also think that recognizing that, again, how nervous, as I mentioned before, and anxious they are, And I think sometimes that, we're so focused on treatment, but we're in that kid's life for X amount of time, especially if you're in, the NICU or in a children's hospital. When you're in the school, you may see that child 4 or 5 years, but in other settings, it's a finite period of time. So the time that we spend preparing that family for the next step and helping them learn to transition from part C to part B and to navigate special services for their kid outside of school and all the accommodations, and then transition from high school to whatever vocational rehab or college or whatever that's going to be. We're doing them a great service. And also considering their siblings because they're part of that family unit.
True. Yeah, that's the cultural navigation piece, right? That's so important that we are really good at. And I'd like to see us, lean into that a little bit more. And I think, when you were talking about, starting an advisory group or a council in the clinic, I think that's great advice. I'm wondering, what if we broke down you said earlier, the 4 tenets, right? The respect, dignity, the information sharing, the participation and collaboration, and we give some, a little bit more information about each one of those, because I think it's so important to understand. And then maybe giving some concrete examples of how that would, work in terms of an occupational therapist or a therapy provider facilitating some of that in their clinical arena, no matter where they work.
Sure. Well, respect and dignity, I think we do that pretty well, but can we do better? Sure. Okay, the first thing is finding out how mom and dad and the child want to be addressed. And if they're non-English speakers, is there a translator available? How do they want to get the information? Do they want to take a little video of you doing therapy with their phone? Do they want it written down? Do they want both? Then you'd be surprised how many families don't know about the child's condition or really understand it. The physician tells them they have X and they're too overwhelmed or scared to ask. And then they come to us and then we end up doing all that education. So doing that over and over, providing them with resources, connecting them to the relevant support groups, really important. And again, having the patience and caring to realize that, again, this is their child. They're very nervous. They may be mourning the dream of having a typical kid, and now it's this new life. And how can we support them through that journey? So it's all, and also teaching them, yes, your child may be a kid with special needs in terms of respect and dignity, but let's respect and give them dignity of their developmental age and let them help with giving the medicines or putting on their orthotics or whatever the task is, or giving them autonomy to make decisions about which therapy exercise they want to do when, and helping, because moms of kids with special needs are so used to doing for the child. And sometimes it's hard for us to step back and let the kid be in charge. And you can't just do that when they turn 18. You have to be doing it all along the way. So
I think some of that is survival mode, right? And helping, with that, right? So yeah, I think these are some good points that I think we're really good at this in the OT world.
Yes.
Regarding information sharing, what does that look like?
So as we mentioned, I think from that first point of contact, when you know that person's coming to the clinic, the wayfinding we talked about, all right? Yes. Here's how to get to the hospital. Here's the parking. Bring a sweater. This is the elevator to take. Signage in the building. And hospitals spend a lot of money with this. I mean, this is a big thing in hospitals because people are always getting lost. And I remember being in Nicholas once, and they had a volunteer who walked me someplace I would have never found it on my own. That made such a difference. Then using TeachBack, okay, during our occupational profile, finding out habits and routines and whatever we're doing. And you present it, as I'm sure folks know, is I want to make sure I'm doing my job right. Can you show me what I just showed you how to put on the, Johnny's splint on his hand? Because sometimes I go so fast. I just want to make sure you know it. Putting the onus on you and not making the parent feel foolish or ignorant is really important. And then asking them again, do they have any questions? There's also something that you can introduce families to, the patient decision aid, which is a guide that I can give you guys some resources to, that has guides that are evidence-based guides for specific diagnoses. And then there's this patient decision guide, which is a very thoughtful, evidence-based way to think about a particular issue. For example, if a family with a child with Down syndrome is debating, should they put the child in an inclusive classroom or maybe in a private school just for Downs kids? And this guide helps them say, who's making this decision? What are our values? What are our choices? So they can really thoughtfully make a good, rational decision that's in the best interest of them and their child. And these are available, and I'll be giving you guys links to them.
Okay.
As we mentioned, is those resources. I think that every waiting room should have a computer or a little program available with, this is the local card, this is the local Down Syndrome Society, this is the local parent-to-parent network. Here's your contact. So you're not alone. And even if you can, connecting them or having that person call them, or setting up, maybe like the hospital that we're affiliated with, they do a special needs fair every year where 600 vendors come and like 2,000 families come to learn about all the different resources in our community for their child with special needs. Goes without saying, avoiding medical jargon. We have PT, SLP, for families, AFOs, they don't know what it is. They'll get to know it, but really try to avoid medical jargon. And remember, with the health literacy principles, 4th grade reading level, most folks are on. And to always even teach back with, please tell me, let's go over about the steps for this. Just tell me. I want to make sure I did my job right. And lastly, with information sharing, peer mentors are instrumental. I will tell you a quick story in the adult world. In one of the hospitals that we have in our district, is that they were working with bypass patients, and they had an NP doing discharge, and they had a lot of reentries, people coming back, readmissions, and they get dinged by Medicare. The minute they had the NP with a peer mentor, who's someone who had already been through a triple bypass, their readmissions went down, because that peer mentor could give them logistical stuff again that the nurse didn't really know. So that's a really lovely partnership. And why can't we as OTs partner with a mom of CP as we're giving home instructions, and she can share how it worked for her and her play with her child? Think about those partnerships, that partnering, that collaborating with families is so critical.
Yeah. And I think NP, by the way, you mean nurse practitioner, right?
Thank you. See, and there, I just did medical jargon.
We do it. Yeah. But, and also I think avoiding things like questions like, do you know about blah, blah, blah? Because they might say yes, and then afterwards they didn't, or they might have thought they did, but you meant something else. And I hear that a lot, like, or this, right? We want to move away from that. And when you were talking about participation, which I think is the third tenet, right? What are some things that we can do to facilitate that? Because I like that idea. We're moving away from that expert model and really being, I don't want to use the word collaborate, because I know that's part of the tenet.
I know what you mean.
We're really having them work together.
Partnering. We're partners. Yes. Okay. Well, I love that you talked about, that we're not the expert. And it really, it's about the climate that you set with that family, as we all know as clinicians. If you set a climate where you're open and warm, and you also know how much that family member has to contribute, they're going to tell you more. We've all had families tell us lots of things. So giving them the choice to participate in therapy, and ask them again, what's important to them and how can we support them? Do they want their mother-in-law to come? Do they want, if they're bringing their 10-year-old along with their 6-year-old who's your client, do they want to do a play session with the two of them so that they can actually engage and have some sibling play? In regards to participation, teaching, again, some of these overlap, teaching the family and the child to be advocates and learning how to navigate the system. Do they know what a patient portal is? Do they know how to get to the patient portal? Do they understand that they can get their medical records and, set up different things? Teaching kids with developmental delays how to not dial today, but 911. Those
Right.
kinds of things, right?
Press 911, right?
Right. Knowing all those things. So I think giving them information and, when is the best time to give information? It depends. I can tell you that I was given this book of stuff when my son was diagnosed with a million different Gilda's Club and the Leukemia Society and the American Cancer Society. And I didn't look at anything for a while because we were just dealing with, will he live tomorrow? But after times, you do look at it. So, but recognizing that they're going to go back to it. And that's when I think the peer mentor or family support groups are great, because that's really where most families get the most support. And over time, you'll find that, they want to have that journey with someone else has been through that journey. Oh, they're now going from the preschool to kindergarten. And I know my kid will survive because Johnny's mother, Johnny survived. His mom said he did well. And she told me how to navigate the IEP, those kinds of things. So I think in participation, it's really setting the climate and also accepting if for whatever reason that's not where they're at, or maybe dad and mom culturally have very specific role delineation, and to respect that. Right. I remember one setting we really wanted dad to be involved and mom said, nope, he's a police officer and this is what he does with her. I do everything else and this is the way our family works. Okay. Mm-hmm. That's their choice. We're not going to change that. Right. So all of those things are really important, but because, and then you could eventually over time, if you're in a hospital or you'll find that a lot of these families often, as myself, want to give back, or they become paid employees in some support group or parent to parent, or, because it becomes an LOL, a labor of love for them too. Because the journey is so challenging and they want to make it better for other families.
Yeah. And I think earlier when you were talking about the patient decision aids, those really got me going. And the patient decision guide, I see that as a huge opportunity to, like you said, meet them where they're at, help them with the information, give them information that really helps them do their due diligence to make decisions, to even know what questions to ask.
Right.
And then also what I love about that process is you can make it to where it's digestible for the family. Yes. And meet them at their temporal context. Because I think, like when you said that you didn't read it at the beginning, but then you came back, I like that there's some hand-holding involved. And people need that when they're in survival mode or just overwhelmed by the avalanche of everything that's going on. So I think that those are tools I know when I was treating would have been amazing to have. Mm-hmm. Yeah, those would have been game changers for sure. Yeah. So when we think about the collaboration part, you said that this was the systems piece. So what does that look like?
Either, depending upon the setting, if it's a hospital, they could be part of the Patient and Family Advisory Council. And I will tell you, many family advisory councils have different offshoots. They may have a NICU. We have a behavioral health. We have a CF. So it may be disease specific. So that's one way. Also, if you're in a clinic, can they sit in on a focus group? Can you routinely ask them for their input every 3 months or 6 months? Or if you're doing a document for families, in our Family Advisor Council, we give the Family Engaged Care stamp, but any document that goes out to families we review not only for health literacy, but for family-friendly language. We don't use the word allow or permit. We try to be more partnership molded and really be very intentional about the words we use to promote that partnership. So do clinicians do that? Can they do that when they're in the clinic with their families? That's another collaboration. And then inviting families to be on councils, the Family Care Council a lot of families don't even know about that. Here in Florida, we have Family Cafe. I'm part of the Florida Family Leadership Network. That is 150 family leaders that all have kids or young adults with special needs who either work or are self-advocates, who we come together to see what we can do at the state level to make it better for families. So there's lots of opportunities, family voices, parent to parent. And families usually feel the need to do that because you get to network and go to the next step with your child and make the system safer and better. The other thing that I didn't mention that we've done at Nova is to have family faculty, right? Family faculty are parents and or patients and or families who come and share their lived experience with students. And when that landmark legislation came out, Crossing the Quality Chasm to Air is Human, 2 years later, they had another colloquium, and they mandated that all health professionals should be given patient and family engaged care education. And today it's in most of our accreditation standards, and using family faculty, it is pretty typical to see family faculty and they're different. I just want to clarify, they're different from what folks may think of standardized patients who are paid actors. But a family faculty may be someone like myself or a friend of mine who lost a child to cancer, and she comes in and shares her journey. Those are, when you hear families' journeys, you don't forget that. And there's actually evidence about how our brain is wired for stories, as you well know. And we remember those stories, and it can impact us when we're treating our next child. Oh, I remember this. Let me be more sensitive to X.
Very true.
That role for families to educate the physicians, the nurses, the OTs, PTs, speech, everybody. Collaboration is so critically important.
And I think that sets the tone when you're a student learning how to do all of this.
Yes.
Yeah, I love that.
And then you're naturally collaborating. You're naturally recognizing that this family is a partner in care, and I can do better for this child if mom and dad are on board and we're working together.
Yeah, so you're kind of primed for that through your educational journey as you become a therapist. So, at the end of the day, we want to have everyone take all this information, be able to put it into practice. So talking maximal impact, that's what I always say. Yeah. What would be the top 3 actionable takeaways that somebody listening to this could put into practice tomorrow?
Okay. First thing I would say is to focus on health literacy and wayfinding. How do we chat with patients? Are we culturally humble in our demeanor? Are we respecting them? Are we using simple words? And are we making it easy for them to get through our system? And that alphabet soup, explaining what OT/L means, or BCB means, or, MD-FAAC. Families don't know what all those letters mean, but I think it's really important that they understand that and explaining that to that. And in terms of health navigation, and I think we talked about this a little bit before, that the time we spend teaching them health navigation is well spent. It's not only for the parent, it's for the child, because you're going to enable them to get through a system safer with better outcomes if we teach them how to navigate that system. The second thing I would say is looking at that advisory council. And again, I realize that a lot of PH clinicians are not hospital-based, but you could start a advisory group in your place, just getting feedback from maybe 1 or 2 families and saying, what could we do better, from soup to nuts, from the time you walk in, or you get to our clinic to the time you leave, and be open to hearing what they say. And they're going to tell you wonderful things too.
And if you're school-based, there's often advisory groups, school-based too, that you could go. And I remember going, and I learned a ton that I hadn't really thought about before. And if you're overwhelmed by the system, these kinds of things are helpful for you to start to put the pieces together a little bit too.
Yes. And just think about how immediately we can include families from the language of our documents to how we welcome them into the clinic. In a big hospital, if you had a peer mentor meeting them at the door of the, Joe Smith's hospital, go, "Hi, Mrs. Jones, you're here to go to occupational therapy today. We're so excited to meet Johnny. Let's bring him back to the clinic. I know it's hard to navigate. You're going to be using this elevator, and here's a map for you." Oh my God, that would be wonderful, right? The person would feel so much more at ease, right? Instead of, "Where do I go?" And oh my God, those little things and how they're welcome to therapy and the policies and do you want a home program? And if you do, which way do you want it? And, and doing that teach back to go over it with them more than once, because, they're coming to our home when they're in the clinic or hospital. We're not in their home, and it's scary.
Yeah. Or even helping them getting the wheelchair out. I mean, it's a lot.
It's so funny you say that, because my favorite people in the hospital when we were going for treatment, outpatient wise, were the valets who would pick up my son's wheelchair and put it in my in the car and chat with him. They knew his name. They knew what he liked. He had friends from the valet to the security guard. They all made the children and the families feel special. And that is really critical. I knew that I would get help taking out the wheelchair and putting it in, and they never made me feel rushed. They were always very kind and considerate and always very supportive. I can't tell you how grateful I feel to those folks. It was the tone that was set, because family-centered care was the mission and vision of that facility.
Yeah, I think this is all really good advice. I love how you said, immediately start to get them involved, get that feedback from them, put them on any committees on the hospital if they are interested, have these guides and, decision-making tools for them. I think these are all practical things that will really be helpful. Thinking about this, and I don't want people to feel overwhelmed, because learning systems is tricky. Maybe going back and self-reflecting is always a little challenging. Thinking, I have to go back and dig through all my paperwork can be a little overwhelming. We're all strapped for time. But is there something that you can kind of tell us to make us, start this journey, any pearls of wisdom that we can think about when we feel like maybe this is a little overwhelming to take on?
Well, I want to just let folks know that there is a website, the Institute for Family-Centered Care, that has a lot of resources. So there are a lot of people have done this, so you can see what's being done. And there's a lot of OTs and PTs and rehab folks that are doing this now. So it's being done. So what I would say is that to recognize how much we learn from our families, and they know their child so much better than us. And that when you truly engage and partner with them, it's the best collaboration. And I also want to say that, this is a journey. All of us, myself included, through my journey with my son and myself and other family members and working in the system, there's always room for change and improvement. The only thing constant is change. So to be open to that, this is a service delivery model that's going to continue to change and grow as health systems change and grow. But if you can just start looking at it through a different lens and think about, what would you want if that was your child? That's very powerful. How would you want if that was your child? How would you want to be treated?
And I like that, right? We're really just one step at a time. Little changes will really turn into big changes for the families, as well as your practice, right? So thank you so much. I really appreciate, Elise, that you told us your personal story and all your experience and expertise. It's been wonderful. And that's all the time that we have for today.
Thank you.
So I do want to thank you.
Thank you so much.
Really appreciate all these great clinical takeaways related to patient and family engaged care. So thanks, everybody.
Bye.
Bye-bye. Thank Thank you for tuning in to this episode of Pediatric Pioneers by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or on your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and complete the quiz for this episode. Pediatric Pioneers also listens to you. If there is a particular practitioner that you'd like to hear from, or if you have a question or challenge that you'd like to explore on this podcast, please let us know by leaving a comment on our Instagram post or by emailing podcast@medbridge.com.